Hi there, my name is Alex BUTWICK and I'm an Associate Professor in Anesthesia at Stanford, and today I'll be talking to you about point-of-care testing for coagulopathy in pregnancy. So for the purposes of this talk, what we're going to be doing are highlighting the important advantages of point-of-care testing for patients who have or are suspected of having coagulopathy related to postpartum hemorrhage. And we're going to review specific characteristics of two commonly used devices, which are thromboelastography, or TEG, and rotational thromboelastometry, or Rotom. We'll be discussing the use of these devices for potentially detecting coagulopathy in the setting of postpartum hemorrhage. So let's take a step back to start with and ask ourselves a simple question. Why should we even think about using these devices in this type of clinical context? And the reason why I ask that question is that we have the availability of commonly used laboratory tests for assessing the coagulation profile. So let's think about the potential advantages of these types of devices. Firstly, they can be used at or close to the patient's bedside. So that makes it a little logistically easier rather than sending off the blood samples to the lab for assessing the PT, the PTT, the INR, or the fibrinogen. Secondly, the ability of having these devices close to the patient's bedside is that it limits time delays. So in other words, you can get this information back much more quickly than what you otherwise may do if you sent off standard labs for the coagulation profile. Now this is important because for patients who experience postpartum hemorrhage, time is of the essence in terms of deciding if and when you need to treat. And we know it's important because when we think about transfusion decision making, over a third of decisions about transfusion are based upon clinical judgment or based upon empirical information. So having the information back sooner, especially if it's detailed on nuance, can be particularly helpful. Thirdly, the information you get back from these devices may help either replace or at the very least supplement the information you get from the lab to assess the coagulation profile. And last but by no means least, this information can help diagnose specific problems with the coagulation profile and to assess your ability to have adequately treated these defects. So they can be used either diagnostically and or therapeutically. So in other words, many have felt that these devices colloquially should be termed as theranostics. You're using them from diagnostic as well as therapeutic reasons. Now, the important thing to reconcile here is that even though we commonly use standard lab tests to assess the coagulation profile, there are a number of experts within the world of hemostasis who feel that these tests may not be very useful in detecting coagulopathy, at least in the perioperative setting. Now the reasons why is that despite many societies recommending that we set a transfusion trigger of at least 1.5-fold increase in the APTT or the PT, there appears to be a lack of high quality information to support the use of this trigger. So based upon recommendations from experts, it may be the case that lab tests are actually fairly poor at assessing whether there's coagulopathic bleeding in patients who are undergoing surgery. And in this important article that was published in the British Journal, these experts go on to say, and I'm quoting from the article, that it seems questionable how long physicians are willing to use these tests for to assess to use these tests for as markers of coagulopathy or for guidance for bleeding management. And this is the last sentence in their article, which is, but as always, old habits, old and even bad habits die hard. So this is a fairly damning indictment of whether we should be considering the use of standard lab tests for assessing whether patients have coagulopathy. So that's probably a good segue for us to start talking about these two important devices that have been popularized for assessing the coagulation profile in patients who are experiencing postpartum hemorrhage. You have the thromboelastograph on the left, and you have rotational thromboelastometry on the right-hand side. And these devices have been appearing in recommendations published by obstetric and obstetrical anesthesia societies when we're managing patients that have severe hemorrhage during the course of surgery, cesarean section, or if they're experiencing PPH. So for example, the American Society of Anesthesiologists have recommended the consideration of these devices when managing patients who experience hemorrhage. We're also seeing information from the European Society of Anesthesiologists as well, and our colleagues in the UK have also included or made reference to these devices in recent recommendations from the Obstetrical Anaesthetists Association in the UK. So let's just briefly look over the similarities and potential differences between the use of these two devices. So to start with, if you're using TEG, you place a small predetermined volume of blood within a plastic cuvette labeled 1. The cuvette is placed in a platform that is lifted up, into which a pin is placed attached to a torsion wire connected to a black box. You push go on the machine and the cup rotates around a very small angle of about 4.5 degrees. Clot starts to form within the well in the cup, and then that puts pressure, or at least that changes the torque on the torsion wire detected by the black box labeled 4. That black box converts that signal to an electrical signal that you can see displayed on a computer attached to the device labeled 5. Now with Rotom, there's some slight but important differences. You still place a predetermined volume of blood within the cup labeled 1, but instead of the cup rotating, a pin rotates within the well of the cup, so that when clot starts to form within the cup, that puts a change in torque on the piston, which is detected by a light emitting diode, or a system within which incorporates a light emitting diode. That signal is then connected to a computer that allows you to see a trace forming depicting clot formation and clot lysis. So the traces that you get with TEG and Rotom may look quite similar, but the parameters that are measured by each of these devices are named differently. So with TEG, you have 4 important parameters that are used to assess clot formation, which are R, reaction time, K time, alpha angle, and maximum amplitude. This provides us with information about the initiation of clot formation, the degree of fibrin polymerization, and also an idea about the maximum strength of clot formation. With Rotom, the parameters are labeled differently. So you have CT, which is clotting time, CFT, which is clot formation time. You still have an alpha angle, and instead of MA, you have MCF, which is maximal clot firmness. So the reference ranges for each of these parameters for TEG are different from those with Rotom. So you can't assume that for one parameter measured by TEG, you'll have the same value if you were to measure it with a Rotom device. So each parameter and reference set of intervals are very specific to each type of device. So let's look at some normal traces. So look at Rotom first. Rotom is a 4-channel device. So what you're getting here is 4 different traces. You have INTEM, EXTEM, FibTEM, and APTEM. So INTEM provides you with information about the intrinsic pathway. So it's activated by the contact phase, and it's very sensitive to deficiencies of clotting factors within the intrinsic system. EXTEM is activated by tissue thromboplastin, so it's very sensitive to factor deficiencies within the extrinsic pathway. FibTEM provides you with information about the fibrinogen component or contribution to clot formation. So with this trace, or at least when this trace is assessed, within the blood sample, you add in a platelet inhibitor. So therefore, any information about clot strength is specific to the influence of fibrinogen. APTEM provides you information about whether there may be the presence of excessive clot lysis. So within this sample, you're placing or you're putting in a predetermined volume of an antifibrinolytic, so that if there is excessive clot lysis, it's reversed in the presence of an antifibrinolytic. The other important thing to note about Rotom is you can get information very quickly after the clot or after the trace begins to form. So you may be able to get an amplitude measured at 5 minutes and 10 minutes. So with this information, you can hopefully act much sooner than if you waited for the full maximum clot firmness to be evaluated. This is a typical normal trace with TEG, where you're seeing the R time, the K time, the alpha angle, and the maximum amplitude. So with TEG on the trace on the computer, you're getting the value for each of these parameters, as well as the reference range for each parameter that you can see at the lower part of the graph. So are there differences when you compare traces from women who are non-pregnant to women who are pregnant? And the answer is yes. So this is an interesting study that was published by Hussein and colleagues, where they took a set of patients who were pregnant and they compared traces with Rotom to those women who were non-pregnant. Now, you can just eyeball these traces and you can see that the pregnant traces looks fuller or fatter. So in other words, they've got a much shorter times for initiation of clot formation, and you've got a much larger alpha angle and maximum clot firmness. So these differences are all to do with the fact that pregnancy is associated with a hypercoagulable profile compared to women who are non-pregnant. Let's get on to the meat of the discussion to determine how we can best look out for coagulopathy. Now, to help us, at least in the operating room or on the labour and delivery unit, there are a number of decision trees or algorithms that have been published either by the device companies or by experts. So here's an example of an algorithm that's been published by Haemonetics, and that makes life a lot easier if you're at the bedside to try and determine what the underlying defect might be before you can decide what's best to do in terms of treatment. For Rotom, or those of you that use Rotom, I would encourage you to check out this excellent website that's published by some colleagues of ours in Perth, Australia. Now, this website provides you with very specific information about defects that you can assess with Rotom and how best to treat those based upon their recommendations. So this is probably one of the best websites that I've seen to help providers in terms of trace interpretation and decision making if you use Rotom at your hospital. So let's sort of dig into this a little bit, and we'll look at examples of traces to start with that are associated with or are due to fibrin deficiency. Now, fibrin deficiency is a topic of great interest to us in obstetrical anesthesia and to our obstetrical colleagues. And the reason why is that there is accumulating evidence to show that if you measure the fibrinogen level during the early phase of bleeding and it's found to be low, this is a major red flag or biomarker at least for patients who may go on to develop severe postpartum hemorrhage. And one of the early studies, which is seminal work by Charbet and colleagues, showed nicely that if the fibrinogen level is less than 300 or at least less than 250 milligrams per deciliter, these patients are at substantially higher risk for going on to develop severe PPH compared to patients that have a fibrinogen level that's greater than 300 milligrams per deciliter measured during the early onset of bleeding. So what does fibrinogen deficiency look like in patients who have blood samples that are measured with Rotom? So we can see here, what I've done on this slide is I've given you a normal looking trace on the left hand side, and by comparison I've shown you a trace where we see evidence of fibrinogen deficiency. So what we're seeing here is that you've got a very skinny looking FibTem trace for a patient that has fibrinogen deficiency compared to a patient that has a normal looking Rotom trace. So this is important because if you're seeing this type of trace for patients that have fibrinogen deficiency, that may then go on to make you think about using fibrinogen supplementation, for example with fibrinogen concentrate or with cryoprecipitate. Now, how do we decide whether the patient has fibrin deficiency if we're using a set of parameters? Well, this is where it gets a little trickier, but if you measure the amplitude on the FibTem profile at 5 minutes and it's less than or at least no greater than 10 millimeters, then you can make an assumption that there is fibrinogen deficiency in this patient if they're experiencing postpartum hemorrhage. Now, how good is the use of FibTem in predicting hemorrhage-related morbidity compared to if we measure the fibrinogen level? And this is an excellent study that was published in Blood in 2014 by Collins and colleagues, who nicely showed that using the FibTem and measuring the amplitude at 5 minutes provides you with the ability to predict a degree of equivalence, whether patients go on to require 4 units or more of red cells or 8 units or more of red cells compared to if you're using a fibrinogen level. Now, the reason why this study is important is that you're getting the information back about a low fibrinogen level, at least with Rotom, much sooner than you are if you're measuring the fibrinogen level in the lab, which can typically take at least 30 minutes and probably more like 45 minutes or longer. Okay, so if you're using TEG at your hospital, what does what does the profile look like in a patient that has fibrinogen deficiency? Well, similar to what we did in the last set of slides, we have a normal looking trace on the left, and we have a trace from a patient that has fibrinogen deficiency on the right hand side. So here you can see that the alpha is reduced, and also there's evidence that the MA is slightly reduced as well. So this information suggests that there is a problem with fibrinogen deficiency. Now, unlike Rotom, where you have a FibTem profile, a normal trace with TEG doesn't provide you with specific information about fibrinogen deficiency per se. You have to do an additional test. Now, there is there is an ability to do this with a functional fibrinogen assay, where you're adding in a platelet inhibitor to the blood sample to determine whether the maximum amplitude reduction is due to a fibrinogen deficiency as opposed to a platelet deficiency. Now, this is fairly early days in terms of the introduction of this test into clinical use. There's some suggestion that the use of a functional fibrinogen test may actually overestimate the fibrinogen level, but we really need more work, certainly in the setting of obstetrical hemorrhage, to determine how accurate the use of a functional fibrinogen test is for patients who go on to have or are experiencing PPH. Okay, so what about decreased platelet function? So again, what we've done here is present you with a normal looking trace on the left hand side and a trace from a patient that has decreased platelet function or number on the right hand side. So what you're seeing here is a decrease in the amplitude at 5 minutes with XTEM and also a decrease in the amplitude at 5 minutes with FibTem. So when you're seeing a reduction in the XTEM profile and in the FibTem profile, this may be suggestive of a patient that has a decrease in platelet function or in number. How does this look like if you only use TEG? So in the case of TEG, what we're seeing here is a decrease in the maximum amplitude, as you can see on the right hand side, in comparison to a normal looking trace that you can see on the left hand side of the screen. What about a patient that has a clotting factor deficiency or deficiencies? So this is where it gets a bit trickier, because in the setting of PPH, assuming that the patient doesn't have inherited or acquired clotting factor deficiencies, we typically see these type of traces later on in a patient that has severe PPH. So it's often accompanied by other clotting issues. For example, a decrease in fibrinogen and or a decrease in platelet number or function. So in this type of trace, what we're seeing here is a prolongation in the R time, suggestive of an issue in terms of initiation of clot formation that may be related to a decrease in clotting factor number, as well as a decrease in the MA and a decrease in the alpha angle as well. What does a profile look like in Rotom for a patient that has clotting factor deficiencies? So it's actually quite hard to find a good profile just with clotting factor deficiencies, because in a patient that has severe hemorrhage, as we've mentioned, we often see other problems as well. So here is a profile that I've taken from an article published by Schokel and colleagues, where they show you that there's a prolongation in the clotting time and in the clot formation time, but also there's a decrease in the alpha angle and also in the maximum clot firmness. When you look at the FibTem profile, you can see that this profile looks extremely skinny. So what this basically suggests is there are multiple problems associated with the clotting profile in this patient, which include clotting factor deficiencies. So this may mean that the patient needs multimodal therapy, not just therapy with plasma to replace clotting factors. So we're going to look at a patient now who has a hyperfibrinolysis. So what does this look like if you have TEG? Well, typically you see this type of trace, which is called a teardrop trace, where you see excessive clot lysis happening much sooner than when you would possibly see this in a patient that has a normal profile. So when I see this type of trace, which is pretty rare, this is a major red flag, because the patient has typically major bleeding that requires the use of an antifibrinolytic. You see very similar looking traces with Rotom as well, where you have excessive clot breakdown happening much sooner than what you would normally expect, a decrease in the amplitude and the MCF in the FibTem profile. But the important thing to note here also is that you see reversal of the excessive clot lysis in the ABTEM profile, which looks very normal. So in other words, you've got lots of clot breakdown happening very early, which you can reverse in the presence of an antifibrinolytic. So this information collectively means that you should be thinking about the use of an antifibrinolytic in a patient that has excessive bleeding in the presence of hyperfibrinolysis. So before we conclude, I guess one of the questions that we still need to ask from a clinical standpoint is, do the use of these devices help us improve outcomes from a maternal and or a perinatal standpoint? And this unfortunately is where we have less information. A recent article that was published by Wickenslow and colleagues, this group of investigators performed a meta-analysis to compare whether mortality or the risk of mortality varied in patients who were treated with point of care base resuscitation compared to patients who were not. And in this forest plot, you can see that the risk of death appeared to be lower in patients who received therapy using point-of-care testing. But the important thing to note in this study is that, or in this analysis, was that there was marked heterogeneity between studies, and the quality of the studies was deemed to be overall fairly low. They also provided information about whether the likelihood of using red cells, FFP, or platelets vary depending upon whether patients were treated with point-of-care based decision making or not. There was a suggestion that there was a reduced likelihood of requiring red cells, plasma, or platelets in these patients that used point-of-care versus those that were not. But again, the quality of the information from these studies was relatively poor, so it's unclear whether we should be changing our practice for decision making using these devices quite yet. So what about, at least for PPH, do we have information to suggest that these devices may or may not be helpful? And again, we don't have an awful lot of information. Most of the information comes from retrospective observational studies. The best of which is probably this study from the UK. It was published in Anesthesia in 2015. And in this study, this is an impact study where they had an approach for managing PPH using a massive transfusion protocol. They changed their protocol to incorporate Rotom, and they also switched out the use of plasma for the use of Restab, which is fibrinogen concentrate. And what they found when they compared the use of products in patients that were exposed to the profile before the change compared to those that were exposed to the profile after the change was that when point of care was incorporated in the profile, as well as with Restab, there was a reduction in the use of red cells, plasma, and also in platelets. So there was at least some suggestion here that potentially the point of care devices may be of some value. There's also been further studies that suggest for managing patients that have very specific causes, such as abruption, that there may be some value here, because these type of patients tend to have a greater degree and potentially more commonly problems with coagulopathy compared to patients that have atonic PPH. So are there any downsides with using these devices? Well, obviously there's costs to think about, but beyond that, these devices require daily calibration, so there's some logistical aspects to using these devices which are important. Providers need to be educated about using these devices if they're going to be used on the labour and delivery unit. This is one of the reasons why we now house these devices down in the haematology department at our hospital. So we don't have to worry about data calibration or education, because these are now done by the haematology techs in our haematology lab. There's also some logistical issues. So if they're going to have them down in the haematology lab, then obviously you need to send the samples down to the lab. But the nice thing about our hospital is with the electronic medical record, this is connected to the TEG view with our TEG devices, so we can see the trace form real time once we log on to the trace view within our electronic medical record, which is quite nice. Now, other things that we don't know are, do we know whether transfusion related outcomes or the need for transfusion differs in patients who use a fixed ratio approach, or patients who receive a fixed ratio approach to treatment, compared to those patients that use a goal-directed therapy with TEG or Rotom? And the answer is we don't know. We don't know whether outcomes vary for all women that have PPH or only for those women that have severe PPH. The other studies that we need to think about doing are comparing the use of TEG or Rotom for goal decision making compared to standard labs, or whether if you use a hybrid approach where you're using standard labs with TEG or Rotom, whether outcomes differ compared to if you use these devices in isolation. And lastly, we need to do direct comparisons to see whether one device is better than the other, to see whether the information you get back from TEG is more helpful in improving outcomes compared to those that use Rotom. So what does the future hold? And obviously things are changing from a technological standpoint. These devices have typically been used at the bedside or in a hematology lab. But what we're seeing now are, in terms of the latest advances of these devices, are that you can get information back much sooner if these devices don't require manual pipetting or more complicated calibration. So both manufacturers have now produced devices where you put blood within a cartridge, you insert within the machine, and then you push go, and essentially you get the information back much more quickly and more easily. So it makes the devices much more user-friendly. So we're seeing these devices now appearing on the market. From Haemonetics, you're seeing the TEG Success, and from the manufacturer of Rotom, you're seeing the Rotom Sigma, which again also uses a cartridge-based, which accounts for a cartridge-based system. So hopefully that provides you with a nice overview about the use of these devices for managing patients with PPH, but feel free to email me or send me tweets on my Twitter feed at algebut, or feel free to log on to my OB Anesthesia Facebook page and you can see the URL for that on the screen. Thank you for your time.